You may have noticed that the last time you visited your doctor, they spent a lot of time typing information into the computer during your visit. This is because most physicians now have electronic health records, or EHRs. And EHRs have really transformed the way health systems operate over the past decade. We in the economics department at Lehigh University have spent a lot of time investigating how electronic health records affect health system performance. What I'd like to do is share with you some of our results and then talk about how EHRs are relevant to the management of the current COVID-19 pandemic. Prior to 2009, a lot of doctors' offices and hospitals were still using papered records to record patient medical information. Now, those paper records were hard to transport across providers. What that meant was that when you went to a physician or a hospital in a different location, they didn't have access to your previous medical history. Now, this could be a problem in certain cases where the treatment of your condition required knowledge of what treatments and conditions you've had in the past. Electronic health records were intended to solve that problem by allowing physicians to record patient information in electronic format and share it with providers all over the country. In order to spur providers to adopt these very expensive electronic systems, the federal government passed the HITECH Act in 2009. And what this act did was it gave providers financial incentives to adopt electronic health records, and it imposed penalties if they didn't adopt them quickly enough. So because of the HITECH Act, most providers have adopted electronic health records in their operations or in the process of integrating them across different locations. We partnered with the Lehigh Valley Health Network in order to study the long-term implementation of an electronic health record system. We did this over a 6-year period and focused on pregnancy care because in that case, women travel back and forth between their outpatient providers and the hospital more frequently than in other types of care, which means having access to their patient information across care settings is important. I'm going to share with you now some of the results from our empirical models. And these I've summarized in 2 figures. In the first one, you're going to see 3 lines. The red and blue lines are confidence intervals that just capture the statistical variability around the main trend. So I want to focus on that main trend, which is the black line. In the initial period between 2007 and 2008, the electronic health record system hadn't been installed, and so productivity was relatively constant. But in 2009, after the installation of the system, you can see that there was a pretty significant drop in productivity. Now, as the system was integrated, which took multiple stages, things moved around a bit. But by the end of the study period, productivity was still significantly lower than before the EHR had been installed. This was surprising, but it has been found in other healthcare systems as well. So to get a little bit more insight into what's causing this drop in productivity, what we did was we looked at productivity per visit, which I'm going to show you on the next graph. In this graph, we're basically capturing the amount of healthcare resources that are devoted to the treatment of each patient during a visit. So initially, that's pretty steady. But by the end of the study period, when the electronic health record system is implemented, we can see the effect of the EHR is to increase productivity per visit. What does that mean exactly? Well, taken together, these 2 graphs tell us that overall patient visits and patient encounters decreased because patients were spending more time with the physician in each visit. And because the physician had more access to their previous history of treatment and their conditions, the physician was able to provide more healthcare services to those patients. And that is what we call an increase in treatment intensity. Now, that will increase costs in some cases, but it may also increase the quality of care, and that's what we looked at next. And so in order to do that, we looked at an index of pregnancy outcomes that's associated with the birth of each baby. And so in this last graph here, what we have is that index, that adverse outcome score over time. So in this case, when the line goes up, it means adverse outcomes worsened at the hospital. And when it goes down, it means there were fewer adverse outcomes. So initially, after the installation of the EHR system, the rate of adverse outcomes actually increased a little bit. We attribute that to the disruptive nature of the installation of the system in the offices, which caused changes in work roles. Physicians and providers also had to learn how to use the new system, which was time-consuming and difficult. But after that learning occurred, and the system was fully integrated across all physician offices in the hospital, adverse outcomes dropped significantly toward the end of the study period. And so what that tells us is that there was a real increase in the quality of care, and it was associated with greater amounts of time spent in physician offices treating the patients because doctors had better information about patients' conditions and previous treatments. From our findings, we can draw some implications about the importance of electronic health records to the treatment of patients during the COVID-19 pandemic. We found that when physicians have better access to a patient's pre-existing conditions and past treatments, they can provide higher quality care. They can treat the patient more intensively, even if that increases costs. One of the key factors to reducing the negative implications of COVID-19 is the protection of patients with pre-existing conditions, such as COPD, diabetes, or heart disease. These patients are at much higher risk of experiencing a negative outcome from a COVID-19 infection. When doctors see these patients, either virtually or in their offices, with EHRs, they can determine immediately whether they have those pre-existing conditions, and if so, they can counsel them better on how to avoid infection. It's also the case that if such a patient were to end up in the hospital, physicians there would be able to better protect them while they're in the inpatient setting from other patients who may have infections. That wouldn't be possible in the case where the only records about the patient's history were sitting in a paper document in the outpatient physician's office. The other thing that's very useful with electronic health record access is the ability to determine whether the patient has been tested in the past for COVID-19, whether they've tested positive or negative, or whether they've had a COVID-19 infection and recovered from it. All these things are important to determining a patient's future treatment trajectory. Another capability that EHRs provide is a means to track infection rates across different geographic locations. Electronic health record systems generate large databases, and those databases can be linked across provider networks through what are called health information exchanges. Many of these exchanges are regional, but some of them are national. That data can be analyzed and used by policymakers to determine where infection rates are increasing and where they're decreasing. Such information is important to the targeting of scarce resources, such as ventilators or protective equipment, that may not be available everywhere due to shortages. By harnessing the data used in EHR systems, policymakers can then decide where to devote those resources. So EHRs are important not just to physicians in the treatment of individual patients, but they're also important to the surveillance of the epidemic. Thanks for listening, and I hope you stay well.